In this video, we'll learn about infective endocarditis. First of all, we should know about the endocardium. See here, this is a cut section of the wall of the heart. When you see here, the innermost lining of the heart is endocardium. Uh, Endocardium is in close relation with the myocardium, which is the thicker layer, which is made up of cardiac muscle cells. And then we have his pericardium. So this is the cavity or the gap which we call it as pericardial cavity. Inside it is visceral pericardium. Outer side we have a parietal pericardium. Okay, visceral pericardium and parietal pericardium. Surrounding that we have a fibrous pericardium. Okay, so now here when we call infective endocarditis, meaning what happens is this endocardial layer, meaning the innermost layer of the heart is infected. Okay, the innermost layer of the heart is infected. This is called as infective endocarditis. So as you can see here, infection of the endocardium, which is the inner lining of the heart chambers and the heart valves, we call it as infective endocarditis. Now, what causes infective endocarditis? Clear? It is typically caused by bacteria. Most common cause is bacteria. Okay, although sometimes fungi or other microorganisms are also responsible for this infective endocarditis. Now, in not everybody gets infective endocarditis, right? It is not very common for people to develop infection of the endocardium because our immune system is really strong. So, who are at risk for this infective endocarditis? We'll see now. There's a patient who is already a known case of cardiac lesion. Okay, patient already is a known case of a heart disease. For example, patient is a known case of ventral septal defect, or patient is already a known case of mitral stenosis, or any other congenital defects also patient can present. Okay, so in these patients they have a higher chance of developing infective endocarditis. Or if a patient gives history of IV drug abuse. IV drug abuse. Okay, what happens here is they use the unsterilized needle, so they can directly insert an organism or a bacteria into the blood vessel. That is why they are also at high risk of developing infective endocarditis. Or because of any other reason, if the immunity goes down, patient will develop infective endocarditis. So what are the symptoms of infective endocarditis? Patient, this is an infection, right? So most common signs and symptoms of infection would be there in these patients. For example, like fever, chills, fatigue, very severe tiredness. There's a muscle pain, joint pain, night sweats. There's a shortness of breath, difficulty in breathing. Okay, there's a swelling in the feet, legs, or abdomen. There's an unexplained weight loss sometimes. The patient can also present sometimes with the blood in the urine because there is a widespread bacteremia, meaning when the infection is involved endocardium, imagine like the bacteria will be there everywhere, like it will be in the blood, right? So what are the signs of infective endocarditis? The classical signs of infective endocarditis is identified by modified Duke's criteria, meaning all the signs of infective endocarditis are grouped into major and minor criteria, and as a whole we call it as modified Duke's criteria. This criteria will aid in the clinical diagnosis of infective endocarditis. So here you can see all the signs of infective endocarditis are grouped into major and minor criteria. Okay, the major criteria is like a positive blood cultures for a typical infective endocarditis microorganisms. I told you some bacteria will cause infective endocarditis, but most common bacteria is Streptococcus viridans and Staphylococcus aureus. These two are most common causative agents for infective endocarditis. Okay, there are other organisms which I'll tell you in the next slide, but as of now, remember, you take a blood sample, and if it comes positive for these organisms, it's a major criteria. Then there is evidence of involvement of the endocardium, okay, which can be demonstrated through echocardiography, showing oscillating intracardiac masses on valves, supporting structures, or in the path of regurgitant jet, or evidence of abscess formation, which I'll explain again in the coming slides. As of now, we'll see the minor criteria signs now. There's a patient has a predisposing heart condition or a intravenous drug use history. Patient has fever where the temperature is more than 38 degrees centigrade, or vascular phenomenon, meaning this involvement of blood vessels, there is inflammation or infections of the blood vessels which can lead to uh, such as arterial emboli. Because of this, patient can present with pulmonary infarct, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhages, or Janeway lesions. Immunological phenomenon such as glomerulonephritis, Osler nodes, Roth spots, rheumatoid factor, or Microbiological evidence not meeting major criteria but consistent with infective endocarditis. Like, see, you have all the signs of infective endocarditis, but sometimes patients like blood culture becomes negative. Okay, in those such conditions, sometimes, such as sometimes there can be a positive blood culture for some other organisms, okay, which does not meet the major criteria, or there can be a serological evidence of active infection with organism consistent with infective endocarditis. This falls under a minor criteria. Now we'll see each of these criteria in detail now. Now, major criteria, we had two findings, right? One is the patient is having a positive blood culture for Streptococcus viridans or Staph aureus, and another one would be involvement of the endocardium. So, as the name is telling, it is infective endocarditis. So, you have to prove that it is infection. Clear? You know, whenever there's an infection, for especially the endocardium, you know it is in direct contact with the blood. So these organisms should be there in the blood also. So when you take a blood sample and send it for culture, you get a positive blood culture, especially for Streptococcus viridans and Staph aureus. The next criteria, major criteria, is endocarditis, meaning the infection has involved the endocardium. So how do you prove that endocardium is infected here? You do an echocardiography. When you do an echocardiography, what happens is there is a oscillating intracardiac masses on valves or supporting structures. It means what happens is, for example, now valve, okay, your mitral valve, there is some bacterial vegetation or some growth attached on the mitral valve. You know, whenever the heart is contracting and relaxing, like during your ventricular systole and diastole, these valves will keep opening and closing. So what happens, every contraction and relaxation, this mass also will move along with the valves. So that is why in echocardiography, if we can demonstrate this oscillating intracardiac masses on valves, or it can be on any other supporting structure, okay, or in the path of regurgitant jet, meaning wherever there's a regurgitation blood flow, in that direction, if there is these masses, or sometimes if you can demonstrate evidence of abscess formation in echocardiography, this proves that your endocardium is involved or infected. Clear? So this falls under major criteria. So it's very easy to remember. See, it is infective endocarditis, right? So you have to prove that it is an infection, and you have to prove that it has involved the endocardium. Now moving on to minor criteria. Okay, before that, I can just give a list of bacteria causing infective endocarditis. I just mentioned two bacteria till now, Staph aureus and Streptococcal viridans. Other than that, also remember sometimes Enterococcus faecalis can cause infective endocarditis, or HESEC organisms. HESEC organism meaning your Haemophilus species, Aggregatobacter species, Cardiobacterium species, Eikenella and Kingella species. All these organisms can cause infective endocarditis. But since these are anaerobic organisms, what happens is sometimes they come negative in blood cultures. Okay, unless you're suspecting this specifically. And Coxiella burnetii can also cause infective endocarditis. Now moving on to minor criteria. Here remember the patient should have the risk factors. For example, he should have a predisposing heart condition or an intravenous drug use history is there, and is presented to with fever where the temperature is more than 38 degrees centigrade, and you see some vascular lesions such as, see now, arterial emboli. As the word is telling you, emboli, what happened is these vegetations were sitting in the valves, right? These were bacterial growth, and these tissues are very soft. These growth was very soft. So what happens if there is hyperdynamic circulation? Sometimes a part of this thrombus or a part of this vegetation can get separated. So a very small piece of the bacteria or a vegetation will be moving in the blood. It can go into a systemic circulation or into a pulmonary circulation depending on which side of the heart is involved. Okay, so this emboli will form. If that emboli goes to pulmonary circulation, it will cause septic pulmonary infarct. Infarct meaning the blood, these emboli, they block the pulmonary blood vessels, so they cause septic pulmonary infarcts. They can also cause mycotic aneurysm, which I'll explain in the next slide. Okay, and remember, if these emboli get blocked, if they block the blood vessels in the brain and conjunctivas and all, they can cause intracranial hemorrhage, conjunctival hemorrhages, or they can present with Janeway lesions, which again I'll be explaining in the next slide. Clear? So these are the vascular phenomenon, meaning the blood vessels are directly involved. Clear? Fourth point would be immunological phenomenon. Immunological phenomenon meaning there is a immune reaction which is taking place because of the bacteria here. Okay, one is the patient can present with glomerulonephritis, and this can lead to presence of blood in urine. Okay, as you saw, some of the sometimes no patient will come with a symptom of blood in urine. So it might be because of involvement of the glomerular. So glomerulonephritis, Osler nodes, Roth spots, or rheumatoid factor. Fifth point is microbiological evidence not meeting the major criteria. Okay, but consistent with infective endocarditis. See, all the signs of infective endocarditis is there, but your blood samples, no, like maybe one sample is positive, but the next one you give after 12 hours, that might come negative. So, or the patient can present with serological evidence of active infection with organisms consistent with infective endocarditis. Sometimes the antibodies, no, the serological evidence may be positive of some infection. So as I mentioned previously, there can be a vascular phenomenon called mycotic aneurysm, meaning this infected material, okay, from the heart valves, they can get dislodged, they can form an emboli, right? They can travel through the bloodstream and they cause damage to the arterial wall. So imagine this is a blood vessel. So your emboli got dislodged, a part of this bacteria is moving like this and it gets attached to a vessel wall and it will start causing weakness of the vessel wall. So there is in the what happens, the vessel wall will start bulging, and which we call it as aneurysm. So damage to blood vessel will lead to aneurysm, and this is mostly due to bacteremia or fungemia. So anytime this aneurysm can rupture easily because the vessel wall is very thinned out. Osler notes. This is what this one. This you studied under the immunological phenomenon. Okay, what are these Osler notes? See, this is the foot. Okay, underneath of the foot, what has happened on your great toe and other toes, what has happened is there's a nodule like structure which is formed here. Okay, these are the nodules in the pads of the fingers and toes. These nodes are caused by immune complex deposition and inflammation within the small blood vessels. So there is vasculitis here. Okay, because there is inflammation of the small blood vessels, these nodes are painful. Remember that Osler nodes are painful. Moving on to Janeway lesion. Janeway lesion is a vascular phenomenon, meaning, see, this is your hand. Okay, imagine this is your hand. What has happened? This is the palm, right? This in the palm, there are red patches. Okay, there'll be a red patches. So these are nothing but your maculas, erythematous maculas. This has happened because of the emboli which has blocked the blood vessels in the palm. This causes hemorrhages, small subcutaneous hemorrhages which are called as maculas. This is your Janeway lesions. Remember, usually palm and sole you'll have this macula or a plain lesion, you call it as Janeway lesion, but you get some swelling or a nodule like structure in the fingertips and in the toes, and it is painful, no? Then we call it as Osler nodes. So now just to differentiate between Janeway lesion and Osler nodes, remember Janeway lesion is a vascular phenomenon which is happening because of a small microemboli which is blocking the blood vessels and it is leading to erythematous macules. Okay, this is just a macules and they are painless. Remember that. And Janeway lesions takes about a few days to weeks to develop. Clear? If the patient once the patient starts developing infective endocarditis, they are mainly seen in the palms of the hands and soles of the feet, and usually these patients know they come the positive because this is the microemboli, septic microemboli which is moving in the blood. So you take a blood sample and see the lesions, then the patient will have, usually they'll become blood culture positive, and Janeway lesions are usually found during acute endocarditis. Osler notes it is an inflammatory phenomenon which has happened due to vasculitis, okay, because the immune complex deposition and inflammation of the blood vessels, there is vasculitis in these patients which leads to this nodule formation, okay, which is painful. These are erythematous nodules. It remember this develops within hours to days and normally seen during in the tip of the fingers and toes, and in these patients, no, usually it's because of inflammation or immune complex reaction it is happening, and most of the cases patient with Osler nodes, no, they are blood culture negative, okay, and they present during the subacute endocarditis stages. So just to summarize now, this is the modified Duke's criteria. The major criteria, remember, you have to prove that it is infection and it has involved the endocardium. So these two, if they are proved, it comes under major criteria. Minor criteria is you have a risk factor and patient has signs and symptoms of infective endocarditis. That is your predisposing heart condition or IV drug use, and fever more than 38 degrees centigrade temperature. Vascular phenomenon, okay, as I mentioned, there is a arterial emboli which is formed, which is causing a blockage in the pulmonary blood vessels. Patient can have a mycotic aneurysm, intracranial hemorrhages, conjunctival hemorrhages or Janeway lesions. As I mentioned, Janeway lesions, remember, it is a vascular phenomenon because of an emboli which is forming a erythematous macular patches in the palms and soles. Immunological phenomenon, because of immune complex deposition, it can present as glomerulonephritis. Osler nodes are nodules which are present in the fingertips and toes. They are painful, okay. Rod spots are retinal hemorrhages where there is a central paleness, okay, in these retinal hemorrhages. Those are called as rod spots, or sometimes they can be positive for rheumatoid factor. Microbiological evidence not meeting the major criteria but consistent with infective endocarditis, such as there can be a positive blood culture that does not meet the major criteria, or sometimes you have a serological evidence of active infection with organisms consistent with infective endocarditis. Like, for example, the culture they're coming negative, but you can have a serological evidence of active infection. Clinical diagnosis is, how do you know? Now you saw there were two major criteria and five points under minor criteria. So if both the major criteria signs are there, okay, like you have proved that it is an infection and you have proved that it is in endocardium, it has involved the endocardium, then it is a definitive sign of infective endocarditis. Or you don't have, they are not they are not positive for these two signs, but they all the five minor criteria the patient is following. So what happens is, then you call it as again a definitive infective endocarditis. Or the confusion would be like, blood culture is negative, but you know the endocardium is involved, or only one major criteria is positive. That means along with that you should have minimum three minor criteria signs. Then only you can again call it as a infective endocarditis. So easier way to remember is, either all the major criteria signs should be there, or all the minor criteria signs should be there, or 50% 50%, at least one should be there, or at least like more than 50% here if you take. So okay, at least three, minimum three should be there. Clear? Then you call it as infective or definitive infective endocarditis. So now, how do you diagnose this? Infective endocarditis, hope you guys are clear now. Definitive infective endocarditis, meaning it should follow this clinical criteria. So whatever I explained till now, modified Duke's criteria, we call it as clinical criteria, okay? Or pathological criteria. Pathological criteria meaning you send some pathological like the samples. For example, some infective focus you have sent, and from the pathology department they tell, okay, there is an active infection which is happening in the endocardium. Then it proves that it is a definitive infective endocarditis. For example, microorganisms are confirmed by culture, and you have demonstrated by histological examination. You've sent a sample of vegetation or that abscess which has formed in the endocardium, and they tell you that okay, it indicates active endocarditis, then that is a definitive sign of infective endocarditis. Sometimes what is possible infective endocarditis, okay, the patient like he only one major or one minor plus one minor criteria findings are positive, then it is a possible infective endocarditis. Or sometimes only three minor is present, there's no major, the infection is all like blood cultures are coming negative, echocardiography is also normal, but only three, my patient is having fever, he can have some Janeway lesions, and he can have some Osler nodes and all, then you know it is it's a possible case of infective endocarditis. But you can, it is, when do you call it as a rejected infective endocarditis, meaning the patient is, you are confirmed that it is not an infective endocarditis. When do you do that? There's a resolution of symptoms by antibiotic therapy within 4 days. Now see here, whenever the patient comes on day one to you, remember, first send the investigation, so all the blood samples, okay, because once you start them on antibiotic therapy and then send the blood sample, what happens is all the organisms would be coming negative, all your culture reports will come negative. So first thing is you send all the blood sample and send them for all investigations. Then once the samples and all has been collected for the investigations, now you start him on antibiotic therapy. Now remember, if it's a case of infective endocarditis, he will not resolve within 4 days. But within 4 days, patient is completely all right, then it is not a case of infective endocarditis. Clear? That means it is a rejected infective endocarditis. Now coming on to treatment. Uh, the streptococcal endocarditis, okay, this is mostly this responds to penicillin or ampicillin in combination with the aminoglycoside. When you give this, becomes the first line of treatment for streptococcal endocarditis. If you have a methicillin resistant Staph aureus, then you give vancomycin. But otherwise, if it's a enterococcal E. coli, right, enterococcal endocarditis, then again ampicillin or penicillin in combination with this aminoglycoside becomes the first line of treatment. So for time being, just remember that penicillin or ampicillin is the, in combination with an aminoglycoside, is the first line of treatment for infective endocarditis. So just to summarize, what we learned is, what is infective endocarditis is, there is involvement of the endocardium. There is infection of the endocardium. We call it as infective endocarditis. So what will be the symptoms? Patient will have the symptoms of usual infection. For example, patient will have fever, chills, severe myalgia, joint pain, tiredness. All these are the signs, symptoms of infective endocarditis. Who are at risk of getting this infective endocarditis? Remember, patient with a pre-existing cardiac lesion, or patient gives a history of, he's a repeated IV drug abuser, clear? Or sometimes when the immunity goes down, patient can present with infective endocarditis. So what are the signs of infective endocarditis? All the signs are grouped under modified Duke's criteria. Clear? Modified Duke's criteria, you have both signs under major criteria and minor criteria. You have 2 major criteria and 5 minor criteria. The 2 major criteria are, your you prove that it is an infection, so you should have a positive blood culture, or you should have involvement of the endocardium. That is your major criteria. Minor criteria is like patient has a risk factor, he is positive for, he has fever, then he has some vascular lesion or immunological phenomena like Osler nodes and all might be there, or sometimes you have a blood culture report which is inconsistent with the major criteria. Okay, so these are the this is your modified Duke's criteria, based on which you start your you come to a diagnosis, and the first line of treatment would be penicillin or ampicillin in combination with an aminoglycoside. Thank you.